Oh.
Yeah, please. You just let us know once. I will suggest.
Okay. I'm presenting a case of Mr. XYZ. He is 60 years old male residing in Agrawala, Bengaluru, and he is studied until 2nd standard and he works as an electrician. And he earns 35,000 per month and belongs to lower middle class according to modified Compressive classification. And his date of admission was 19th April 2025 on examined the same day. And this side? Okay. Chief complaints: weakness in the right upper limb since 6 months, tingling sensation in the right upper limb since 6 months, weakness in the right lower limb since 5 months, neck pain since 4 months, and weakness and tingling sensation in the left upper limb since 1 week. So, history of present illness. Patient was apparently normal 6 months ago when he developed weakness of the right upper limb, which was insidious in onset, gradually progressive. Initially in the index and the thumb finger of the right upper limb and gradually progressed to the entire limb. Associated with tightness of the right hand in morning after sleep for about 10 to 15 minutes, and it had no relieving factors. And he had a history of inability to button and unbutton shirt, history of difficulty in bringing food to mouth, and history of difficulty in combing hair. So there was no history of slipping of objects from hand. And he also complained of tingling sensation of the right upper lip since 6 months, which was insidious in onset, gradually progressive. Initially started from the palms and fingers, which progressed up to the entire lip, not associated with loss of sensation and pain, aggravated on exposure to cold and no relieving factors. He also complained of weakness in the right lower limb since 5 months, which was insidious in onset, gradually progressive. Initially present in the distal part of the lower limb, which progressed up to the proximal part of the lower limb. Associated with tightness and swaying while walking after sleep for about 10 to 15 minutes. Not associated with tingling sensation, no aggravating or relieving factors, and no history of loss of sensation. And he had a history of slipping of footwear while walking since 4 months, and he was aware about it. History of dragging of foot, history of inability to walk fast and feeling of giving away while walking. And he had a history of requiring support to get up from squatting position, and he had a history of climbing up and down stairs 2 feet per step with support. And he had a history of difficulty of wearing trousers in standing position. There was no history of fall while walking in dark and washing face. No history of difficulty in walking narrow paths, and no history of difficulty in turning in bed. He had a history of complaint of neck pain since 4 months, which was insidious in onset, dull aching type, not radiating, and no aggravating and relieving factors. He also complained of weakness and tingling sensation of the left upper lip since 1 week, which was insidious in onset, and weakness was present in the left hand, and tingling was present in the fingers of the left hand. And there was no loss of sensation and pain. It was aggravated on exposure to cold, and there was no relieving factors. He had no history of inability to button and unbutton shirt, and no history of difficulty in bringing food to mouth. And there was no history of slipping of objects from hand, and no history of difficulty in combing hair. And there was no history of difficulty in neck holding or raising head from bed, and there was no history of sudden jerky movements, no history of neck tilt or click-like sounds on neck movement, no history of loss of sensation over entire body, and no history of electric shock-like sensation with neck movement. He had a history of interrupted flow and dribbling of urine. He had a history of constipation since 1 day. There was no history of giddiness on getting up from recumbent position. No history of breathing difficulty, no history of difficulty in holding urine, increased frequency, difficulty initiation, and no history of burning micturition, sensation of incomplete evacuation, no history of cough or fever, and he had no history of headache, nausea, vomiting, memory disturbance. There was no history of loss of consciousness, seizures. There was no history of loss of smell, visual complaints, diplopia, and there was no history of facial sensory loss, deviation of face, difficulty hearing, deglutition, voice change. There was no history of difficulty in rotating neck, shrugging shoulders, tongue protrusion, articulation of speech, tremor or unsteadiness, and reaching the target. Past history, there was no history of similar complaints in the past. There was a history of surgery of the left ankle due to trauma to the left Achilles tendon, and history of fall from stationary scooter 4 months ago, And he had a history of exposure to electric shock 1.5 years ago in his right arm, which turned black and returned to normal color gradually. And he is a known case of hypertension since 1.5 years and is on medication. He is not a known case of diabetes mellitus, tuberculosis, epilepsy, thyroid disorders, and asthma. And there's no similar complaints in the family. He consumes a mixed diet and his appetite is reduced since the last 3 months, and his sleep is adequate. He has a dribbling of urine since 3 months and constipation since 1 day, and he denies any habits.
Okay, we'll analyze the history first quickly. So apparently he is a well-preserved person until 6 months back, I think. Some RTA happened just before that or after this?
Ma'am?
4 months, huh? Some accident happened.
4 months. Because of this, he fell down, ma'am.
So that accident happened after the onset of his disease, no?
Yes, ma'am.
Okay. So you told that there is weakness of the right index finger and thumb.
Yes,
no?
ma'am.
So what was the manifestation? You had difficulty in buttoning.
Yes, ma'am.
Okay. So buttoning happens by what action?
It's fine motor.
Yes. So opponent, opposition. No? Buttoning is by opposition movement. So apparently what is symptomatic is weakness evidenced by opposition. Opponents have become weak. That is the thenar muscles.
Yes, ma'am.
And what about why did he say that there is weakness of index finger? Was there any difficulty in flexing the index finger or anything like that?
Initially, he couldn't hold anything with his the index and the thumb finger, ma'am.
Like holding a pen like that, huh?
No, he felt it was weak, that his normal strength was not present in those two fingers.
Okay. So he felt that his index finger and the ring finger are weak. Index finger and the thumb are weak. So what are the muscles that could be the causative thing apart from thenar muscles? Thenar muscles are for the thumb, no?
Yes, ma'am.
For the index finger?
Flexor, digital.
What are the muscles? If the index finger was also weak, he had difficulty in holding objects between the thumb and the index finger, apparently from the history, no?
Yes.
So the muscles that are in the index finger are intraossei, lumbricals, as well as the extensors and the flexor muscles, which are inserted into the long forearm muscles, which are inserted into the index finger, both in the flexor compartment and the extensor compartment. Extensor digitorum superficialis. Then you have got the flexor digitorum indicis. So any one of them might have been weak. When the patient says that opposition was difficult, you think it is the opponent muscle. That belongs to thenar component. So what are all the things that go through your mind if somebody comes to you 6 months back and tells you this is the problem? Thenar, whether the nerve supply or the muscle. So it's a purely motor. At that point of time, it is only weakness.
Yes, ma'am.
At that time, 6 months back, he had only weakness. It's a motor syndrome. So what are all the structures you will consider at that time, 6 months back, when that person has come to you? He is a 60-year-old person doing some physical labor, no?
Yes, ma'am.
So thumb, which muscle is, so it may be a disease of the muscles that we just now enumerated. Thenar muscles and the lumbricals and the intraossei and the flexor and extensor muscles which are supplying the index finger. But generally, muscle diseases are not selective like this in this pattern. So is it a muscle disease? Very unlikely. So like I'm just telling you how to ask questions. When the patient has come to you first. So can it be a muscle disease? Very unlikely. Opponents is weak. So can it be a nerve disease? So what is the nerve disease? What is the nerve that supplies the thenar muscles?
Median nerve.
Median nerve. So if it is the median nerve that is affected, what is odd for median nerve alone?
Carpal tunnel.
You see, index finger is not supplied by the median nerve. So so it is more than the median nerve. So if you think it is median nerve, it appears that some muscles like the intraossei, the lumbricals, intraossei are supplied by the ulnar nerve only. So all these muscles which are little more than the median nerve is affected. So we will be careful before we say this is a carpal tunnel syndrome. You said carpal tunnel syndrome, very common condition, but that will affect mainly the abductor pollicis brevis, the thenar muscles on the outer part of the thenar eminence is the one which gets affected, but the index finger is generally spared. And you have said that the flexion of the index finger, that is the lumbrical. Then you have got the interossei. Interossei are fully supplied by the ulnar nerve. It is not getting any supply from the median nerve. So it is more than the median nerve. So can it be muscle disease? Very unlikely. Can it be myoneural junction? It cannot be, because myoneural junction diseases affect the proximal muscles, eye muscles, and swallowing muscles. They do not start with the distal muscles of the upper limb. So it is the next motor condition, very unlikely. So can it be median nerve? It is more than median nerve. Yeah, apparently the intraossei is also affected, which is supplied by the ulnar nerve. So then next is the root. So can it be a root? So yes, so if you next we will try to find out the radicular supply of the upper limb. So what are all the roots that supply the upper limb?
C5 to T1. Ma'am.
Yes. What is the muscle supplied by the C5 root?
C5 root deltoid.
Yes, agreed. Very good. Deltoid, agreed. Very good. Just to know the anatomical pattern only, because basic things at your level, no? Agreed, very good. What other muscles? Supraspinatus, infraspinatus, subscapularis, and biceps, no? So C5 is a root which supplies lot of muscles: deltoid, supraspinatus, infraspinatus, subscapularis, and biceps. What are the muscles supplied by the C6 roots? C6 root. Brachioradialis. So mainly it is brachioradialis. That is a semi-prone flexion of the elbow. That is the action of brachioradialis. So mainly C6, because we say many roots are shared. But what is called ultimo moriens? Ultimo morien is the most important root. So we will have sharing of the roots above and below. But the most important root is the root by which we go. So C6 is brachioradialis. It's a very small motor supply for C6 root. What about C7 root? C7 root supplies triceps, pectoralis major, latissimus dorsi, wrist flexors, and wrist extensor. So it's again a huge root. It supplies the triceps muscle, pectoralis, latissimus dorsi, then wrist flexors and wrist extensors. So that is C7 root. Then what about C8? All the small muscles. All the small muscles of the hand. So if it is at the level of the root, this is not fitting into a specific radicular territory. If some of the small muscles are involved, but it is not fitting into the radicular territory. Next, we will go to the inside the spinal cord. After the root, what is there? In between the root and the nerves, you have got plexus.
Yes.
So can it be in the plexus, brachial plexus? Can it be in the brachial plexus? So brachial plexus involvement, if it will be a pain in the location of the plexus, and motor involvement will be in the distribution of nerves. So whether ulnar nerve or median nerve or radial nerve, like that. So we thought that there is some overlap in the distribution of the nerves also. So to call it as a ulnar nerve or median nerve is not possible with the history that we got. The history may be wrong also. Maybe the patient did not have selective weakness of the thumb and the index finger. The whole fine grip might have been weak. But patient may be saying because we use that more, and that on the right hand, the small muscles Other 3 fingers are only adjoint fingers. Primary action comes from the thumb and the index finger. So he might have told like that. That possibility is there. But I am discussing for the theory part of it. No. So if it is a plexus, brachial plexus will produce pain in the location of the plexus. So patient will present like a chest pain. Brachial plexus is in the chest. So chest pain on the left side or right side, and followed by the weakness in the distribution of nerves that come from the plexus. Commonly, it is the axillary nerve. The distal nerves are very rarely symptomatic except in traumatic injuries of the brachial plexus, like birth injury. When the small baby is born, they have got some abnormal lie. So the brachial plexus get pulled. Then only it is a avulsion injuries. There the pattern can be different, but otherwise it is usually pain in the location of the plexus and the axillary nerve or the nerve to deltoid. They are the ones which get involved, not the distal nerves. So it is very unlikely to be in the distribution of the nerves also. In the plexus also. So can it be beyond that? You have got the anterior horn cell inside the spinal cord. So can it be in the distribution of the anterior horn cell? Anterior horn cells can select in what one root there are so many motor units. If you take C5 root, there are so many motor units. In motor neuron disease, it is not the root, it is not the nerve, it is not the plexus, but it is the motor units that becomes weak. So in an anterior horn cell pattern, that is possible. That is selective involvement of the motor units, not motor nerve. So motor unit means, supposing you take C5, we thought that deltoid, biceps, supraspinatus, infraspinatus, subscapular, all these muscles are supplied by the C5 root. But supposing it is an anterior horn cell or a motor unit in the C5 territory, you will find that the deltoid is wasted, or one part of the deltoid is wasted, and all other muscles supplied by C5 root is normal. That is motor unit. So motor unit is selection within a territory of a root. All the muscles supplied by that root will not be equally affected because the root is not actually affected. It is only the motor unit that goes through a root. So all the muscles supplied by that root will not be affected. So when it is a purely motor, weakness of 2 fingers, it is possible to be in the anterior horn cell level. Possible. Next, can it be in the upper motor neuron? Beyond that is the upper motor neuron. Below the anterior horn cell is the lower motor neuron. Above the anterior horn cell is the upper motor neuron. So what will be the manifestation when the upper motor neuron is affected?
Spasticity.
Okay. Weakness. Now we are discussing not about the tone. Spasticity is tone that you get when you examine. No? Here we are discussing the weakness. No? So what will be the pattern of weakness in upper motor neuron disease? It will be the fine movements. So what term do we use to describe that? Kinetic melody. You see, there is no muscle paralysis. In upper motor neuron disease, unlike the lower motor neuron from anterior horn cell downwards, there is paralysis of muscles. Whereas beyond in the upper motor neuron, there is only movement paralysis. Muscles are normal. So in upper motor neuron disease, there is movement paralysis, no muscle paralysis. And which movement needs the finest coordination, that becomes the worst affected. So finest coordination is needed for finest movements, like writing, typing, piano playing. So those movements get affected. So that is called kinetic melody. So movement has got a music. That is kinetic melody. So fine movements get affected. And you check there is any wasting or muscle weakness. There is no muscle weakness, no hypotonia. So it could be at the level of the anterior horn cell, we thought, because it is not fitting into any root zone or nerve zone. That kind of pattern is in anterior horn cell disease. Second, This could be an upper motor neuron involvement because your patient has got fine movement involvement. So it may be a movement paralysis. So so closest thing you will think when the patient has come to you at the beginning of the disease. You see, at the end of the disease, all of us will diagnose because it is easy for us. The whole picture would have unraveled. But in the early phase, you have to use a lot of exercises to localize the condition. So at that time, if he has come to us, we will think of two conditions, whether the disease is involving the anterior horn cells because it is purely motor, and second, is it involving the upper motor neuron? So the fine movements have been impaired. So at this point, as an undergraduate student, I want you to tell me the gross differences between upper motor neuron and lower. We went through the lower motor neuron and we went up to the upper motor neuron. Just tell the points to differentiate. That is what will be your questions, no? Upper motor neuron on the right side and lower motor neuron on the left side, and put points 1, 2, 3. Tell me.
Upper motor neuron will have increased tone and
so upper motor neuron patients can have increased tone, whereas lower motor neuron patients have decreased tone. Agreed. Very good. Second point.
And upper motor neuron has exaggerated deep tendon reflexes.
Yes.
And here it can be decreased or it is absent.
So in lower motor neuron disease, usually reflexes are absent or normal or sometimes decreased depending on the type of disease. Whereas in upper motor neuron, deep tendon reflexes are exaggerated. Next, what happens to superficial reflexes?
Superficial reflexes are absent in both.
Very good. So superficial reflexes are lost and deep reflexes are exaggerated in upper motor neuron. Whereas in lower motor neuron, both superficial and deep reflexes are lost. Fourth point.
Fourth is plantar reflex. There is extension in UMN and in LMN.
If that is involved, it will show like that. Agreed. Fifth point.
There is muscle atrophy in LMN. There is no muscle atrophy in UMN.
So, very good, very good. So, in human disease, there is no wasting. Instead, what happens? A long duration human problem, the whole limb might become small due to disuse. That is called hypoplasia. So, the whole limb might become small, very long duration infantile hemiplegias. Hemiplegia which occurred when the child was 2 years. And he comes to you when he is 60 years or 20 years. You will find that side of the body, whole side of that body is small. I'm sure you might have seen children with infantile hemiplegia, they grow up into adults. And when they come to us, you will see that side is small. That is called hypoplasia. That is not wasting. So the whole limb becomes small. That is called hypoplasia. That happens in upper motor neuron disease, whereas in lower motor neuron disease, wasting happens. Next point, as I told you, there is movement paralysis. That's the most important point. Movement paralysis in upper motor neuron disease, whereas muscle paralysis in lower motor neuron disease. So when you examine, the muscle pattern will be based on the territory. It may be nerve, it may be plexus, it may be cord, the muscles that are supplied by that element territory will be involved. Whereas in UMN, there is no such territory. It is a particular movement. That we call it as voluntary movement and melody of the voluntary movement. So, reflex movements will be preserved. Voluntary movement will be obeyed. Whereas in element, both voluntary movement and reflex movements are lost. Both voluntary and reflex movements are lost in element. In UMN, voluntary movements are lost, reflex movements are present. That is why sometimes patients with upper motor neuron disease, they are having paralysis of grade 2 or so on upper limb. And when they are yawning, they will move that limb. Or suddenly, a paralyzed person with an upper motor neuron disease sees a snake. He is lying down with no power. He might jump out, but later he will fall down. So that's a reflex movement activated through another pathway. So voluntary movements will be impaired, and that too the finest movement, that is the kinetic melody. whereas reflex movements are preserved. That manifests as reflex moving of that paralyzed part during yawning. That we call it as pandiculations. It is called pandiculation. Supposing we are thinking, why is my patient acting for some benefit in the job place or something like that, and you go stand outside and suddenly you watch that when he's yawning, his hand is moving. And you start thinking what is not moving is malingering. But it is not so. By seeing a snake or by seeing a sudden exciting phenomena or yawning, they can have a movement because the reflex movements are preserved. Just like tendon reflex. So these are reflex movements like tendon reflex. You know, tendon reflex, you only said, becomes exaggerated. In the paralyzed limb, tendon reflex is exaggerated. A manifestation of that only is pandiculation and reflexly moving a body part. So these are the various differences. Very good. You are very well versed. You have told most of the differences. So this is our learning point in these symptoms. So either patient has got an anterior console or an upper motor neuron involvement, we will keep it like. So it is now apparently either of these two. So next symptom, insidious onset, slowly progressive, initially started palms and fingers, progress to the entire limb. Slowly the whole limb became affected. What was the onset to peak time from the distal part to the upper limb? How much time it took to involve the whole limb? The whole limb got involved, no?
Yes, ma'am.
How much time it took?
He told it was within a month.
How many? 1 month?
Yes, ma'am.
Okay, so it is it's quite fast, I think. We cannot say it is slow, no? Quite fast. The whole upper limb became stiff or flail or wasted. What was the nature of that upper limb, which whole weakness of the upper limb?
He told it was stiff in the morning.
It was stiff.
Hmm.
Okay, whether it is the limb stiff or the joint was stiff? Morning stiffness, usually you get in joints, no? So did you have shoulder pain or joint pains and that became stiff, or the whole limb was stiff?
He didn't have any joint pains, ma'am.
He didn't have any. So the whole limb became stiff.
Yes.
So at this point, when the whole limb has become stiff, where would you like to place? What are all the territory? Now, next level of, so we thought whether it is anteroconsole or upper motor neuron from the first symptom. Now, next symptom, this is involved at what level? That is the question. Next question. No? So it is a monoparesis. So when the whole upper limb has become involved and it is feeling stiff, probably it is closer to upper motor neuron, if it is true. No? So what all situations you get a thing like that? One upper limb is stiff and he is having problem with the fine movements. So it can be pyramidal system, it can be extrapyramidal system. Both are possible. I'm just discussing, we are not knowing anything about the case. We are not made a diagnosis. So one upper limb can become hypertonic when there is involvement of the corticospinal tract or when there is involvement of the extrapyramidal tract. Parkinson patients, they also come with usually starts in the upper limb only. That is more common. So a stiff upper limb is a very common presentation in Parkinsonism. I hope you might have seen 1 or 2 patients with Parkinsonism. So their upper limb is stiff. So then when you examine, the stiffness will be rigidity and not spasticity. And they may have some tremors. So increased tone in one upper limb is a monoparesis. And if it is extrapyramidal, there will be rigidity and tremor. If it is, it can also happen in pyramidal disease. Pyramidal disease, cortical monoparesis. You have heard of cortical monoparesis? Motor cortex is there, no? Motor cortex. So if you have a small infarct, demyelinating plaque, or any granuloma involving the upper limb area, you know that there is something called homunculus. You know homunculus, you have studied in your anatomy. A man is represented in the brain in a particular fashion, and that is called homunculus. So if it is in the homunculus, the leg is in between both hemispheres. Below the hip is in between both hemispheres. Head and neck and upper limb is in the precentral gyrus, in the superolateral surface of the brain. So in that area, the hand has got a large area. It's a quite large strip in the superolateral surface of the brain. If there is a lacunar stroke, we call it as pure motor syndromes. So pure motor strokes, pure sensory strokes, ataxic hemiparesis, and dysarthria clumsy hand syndrome. These are the lacunes. So they involve small areas, not like the internal capsular hemiplegia. So it could be a cortical monoparesis. If it is a spasticity and not rigidity. If it is rigidity, you will think extrapyramidal. If it is spasticity, it can be a lacunar stroke in the precentral gyrus on the superolateral surface. The points that will help us, one, as you said, spasticity. So instead of rigidity, you find spasticity. Second, exaggerated reflexes are always present in pyramidal disease, whereas in extrapyramidal disease, reflexes can be normal, depressed, rarely it can be brisk also. Then finger flexion reflex, that will be exaggerated in pyramidal disease. That is not exaggerated in extrapyramidal disease. The most useful point, if the patient tells you that at one point, I had a jerky movement, seizures, motor seizures. The person had a seizures, it is favoring a cortical monoparesis. Motor strip lesion, whether it is vascular, demyelinating tumors or anything, it can present with seizures, whereas extrapyramidal doesn't present with seizures. So that is cortical monoparesis. So we will collect all this information. You told about history of present illness, no? So what you are supposed to tell is, just you are small girl only, I know that, no? What you are supposed to tell is not blindly all the symptoms of the neuraxis. You have a particular phenomena with which the patient is presenting. So what are all the causes for that particular symptom? That should be the significant history of past illness. So you don't have to start from the first cranial nerve and tell everything, which may not have any relevance to your patient's symptom. So you have to cultivate that habit. But if your teachers tell you to tell all the neurological symptoms, you can tell. But maybe they are intending to make you revise all the nerves. But the way to tell history of present illness, you are telling about the history of present illness. So present illness is there and it has got a history. So when you think it is pyramidal or extrapyramidal, that kind of symptoms only you should highlight and say it is present or not. Then everybody will know you have gone through the history of that present illness, not the history of whole neurological disorders. That is impossible. But you told like that, it's very much, it is a small, you are small girl, very small girl. So it is very much okay. But how to take history of present illness is there and related history. What all thought process went through your mind while traveling with the patient. We are traveling for the last 6 months along with the patient longitudinally. So at that journey, what all things went through your mind as a possible diagnosis and differential diagnosis. That should be the history of present illness. So you will tell about my patient never had seizures, he never had tremors. No? So all those histories you can tell, then people will know it is on the right side. Did he have any alteration in the speech and language? No. So all this, if you say, you have thought about a cortical monoparesis and you have thought about a Parkinsonism which starts in the upper limb. So next level of weakness, one upper limb. What is the next level of weakness? Spinal cord. No. One is the cortical monoparesis, next is the spinal cord. In the spinal cord, I don't know whether you have been told, a stiff upper limb can be the starting point of a spinal cord disease. And that is called Ellsberg phenomena. Have you heard of Ellsberg phenomena? That is a U-shaped pattern of evolution of a spinal cord disorder with upper motor neuron involvement. With lower motor neuron also it can happen, spinal cord. That is more common. But it can start with upper motor neuron. That is one upper limb. Lower limb of that side, then opposite lower limb, then opposite upper limb. That is called Ellsberg phenomena. Have heard that? So that is a pattern which is seen in spinal cord, where when the person presents to you with that upper motor neuron feature, that will look like a cortical monoparesis. It will not have seizures, it will not have tremors, it will be monoparesis of upper motor neuron type in one upper limb. And later, soon, like your patient, it will follow. That is called Ellsberg phenomena. So Ellsberg phenomena, how does it happen? So you are surprised. In the cortex, you have got a small area. Whereas in the spinal cord, where is it that one upper limb is there? So then you have to think of a pattern called lamination. You know that there is a lamination in the corticospinal tract, lamination in the spinothalamic tract, lamination in the posterior column. You have heard of all that, no? Lamination, no? So lamination is the way that the various limbs are represented in the pyramidal tract, spinothalamic tract, and posterior column. In the posterior column, the upper limb fibers are outer and the sacral fibers are inner. Hello? 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 சொல்லுங்க. சொல்லுங்க. சௌரப் வருதா? சரி, தோசை சுட்டு வைக்கணுமா? எப்படி தோசை சுட்டு வைக்கணுமா? My husband is calling, 1 minute. சரி சரி, நான் கிளாஸ்ல இருக்கேன், அவன் மேல இருக்கா. My husband went for a Tirthadana to Pasuvati temple at Nepal. So he is returning tonight. So he is calling me. That is the thing. Sorry for the interruption. No? So in the posterior column, there is a lamination where the upper limb fibers are outer and sacral fibers are inner. Whereas in the corticospinal tract and spinothalamic tract, the sacral fibers are outer and upper limb fibers are inner. So spinothalamic and corticospinal, the lamination is same. Sacral fibers outer and upper limb fibers inner. It is reverse in the posterior column. So in the spinal cord, if you want to get a monoparesis of one upper limb, the medially placed fibers of the corticospinal tract has to be involved. When that gets involved and patient presents from that starting point, that is called Ellsberg phenomenon. So how can a disease start from there? That is the next question. No? Are you a bit to follow? Am I making, I am comprehensible, no?
Yes, ma'am.
Am I clear enough?
Yes, ma'am.
When I am not clear, you tell me, no? I know you are small girl only. So if you feel I am not clear, you just tell me, no?
Yes, ma'am.
So in the spinal cord, when can this happen? That's very important, very relevant for the surgeon, no? So you have got a blood supply for the spinal cord. You have got 2 posterior spinal arteries, 1 anterior spinal artery. And these 3 arteries are linked by arteries called arteria corona. So they run from the posterior spinal to anterior spinal artery. And they connect. So they connect, all these 3 arteries are connected by arteria corona. From here, end arteries penetrate into the substance of the spinal cord. From this circle formed by anterospinal artery, postspinal artery, and arteria corona, end arteries penetrate into the substance of the spinal cord. And these end arteries are in 3 crucial locations. One is anterior horn cell. These end arteries means they are not anastomotic arteries. Anterior spinal artery, postspinal arteries are anastomotic arteries. From this corona, arteria corona, the arteries which penetrate into the spinal cord do not anastomose. They are end arteries in the terminal zone of anterior condyles of every segment, crossing spinothalamic tract as well as the medial pyramidal. You can imagine the transection of a spinal cord. You see, if you draw the transection of the spinal cord and to put two posterior spinal arteries, put one anterior spinal artery, link them by arteria corona, and you have got the corticospinal tract there, and you have got posterior column posteriorly, and you have got the crossing spinothalamic tract. You know that spinothalamic tract is of two components. One is the ascending spinothalamic tract. Next is the crossing spinothalamic tract. Spinothalamic tract ascends, but it is not crossing as a whole. 2-3 segments join together and cross to the opposite side. So this crossing spinothalamic tract is in the ventromedial part of the spinal cord. And one end artery is going from the arteria corona and supplying the crossing spinothalamic tract. Another end artery from the arteria corona goes and supplies the medial pyramidal fiber. And another end artery supplies the anterior console. All other areas of the spinal cord are supplied not by end arteries, by anastomotic small branches which come from these arteries. Whereas these 3 arteries are end arteries. So supposing you have got a patient's spinal cord disease, which is starting from the place where the end artery that supplies the crossing spinothalamic tract is located, then first symptom will be suspended dissociated anesthesia. So you will think my patient has got syringomyelia. But when you investigate, you don't find any syringomyelia. That is called pseudo-syringomyelic presentation of spinal cord disease. Pseudo-syringomyelic presentation happens due to ischemia to the crossing spinothalamic tract because that is supplied by a non-anastomotic sulcocommissural artery. These end arteries are called sulcocommissural artery. So non-anastomotic sulcocommissural artery supplying. So you clinically you diagnose syrinx, radiologically you do not demonstrate a syrinx, but some signal changes in the ventromedial part of the spinal cord. So that is pseudo-syringomyelic presentation of a spinal cord compression. Next is the anterior condyles. So the anterior condyles can be ischemic and patient may be spastic below. So you will diagnose MND. But patient is later developing bladder, other sensations, and then you know it is not motor neuron disease. So motor neuron disease mimic by a spinal cord disease happens when the sulcocommissural end artery, which supplies the ventral horn, is affected. That is the second false localizing presentation of a spinal cord disease. And the third false localizing is the Ellsberg phenomenon. If the end artery which supplies the medial pyramidal fibers is occluded because the whatever is causing the compression, either vertebral disease or a neurofibroma or a meningioma or a disc, it is sitting at the mouth of the sulcocommissural artery which goes and supplies the medial pyramidal fibers. Then it will start as Ellsberg. So what is the importance? Are you able to guess? If you don't guess, no problem. Because you are only an undergraduate student. Absolutely no problem. You see, you do a imaging at that time of the brain, spinal cord. We don't know where is the pathology. Finally, you find a disc disease there, no? And then you tell you will operate the disc and you will be all right. Will you be right or wrong? You will be wrong. That is the relevance because it is infarction. The disc may be very small, but the patient's problem is due to the sulcocommissural artery, which is compressed by the disc. And what produced the disability is the medial pyramidal infarction. It is not medial pyramidal compression. So supposing you are working in a Western country where people will want you to tell them what is expected. You can say that I can remove the disc so that you do not progress to a progressive myelopathy. Your disc does not keep on bulging or the tumor does not keep on growing. So further elaboration of the myelopathy can be prevented. But what has happened is not due to compression. It is due to infarction. Due to the sulcocomicial artery getting infarcted, and that component will not improve. So the importance of Ellsberg phenomena is of prognostic relevance to the patient. So it's a right hand. So he may want his right hand. So you should tell that you started as Ellsberg phenomena, even though there is a compression as the pathology. Yeah, starting as Ellsberg is due to infarction. So this part will not improve. So it's a prognostic relevance. So 3 locations we are now thinking, whether it is an extrapyramidal, then you will expect a tremor rigidity when you examine. Is it pyramidal? Then you will find exaggerated reflexes, loss of fine movements, no? And seizures may be there from the history, then you are lucky. There may be some degree of speech and language involvement because it is right side. Then it is a monoparesis. Or is it an Ellsberg phenomena, in which case it will not have rigidity, it will not have tremor, it will not have seizures, it will only have exaggerated reflexes and spastic weakness. So then it belongs to the spinal cord, the heralding event of an Ellsberg. So these are the 3 differential diagnoses we are considering when the patient completed his weakness to the whole of the right upper limb. Is it an evolving Ellsberg? These 3 questions come at the second symptom. So your differential diagnosis becomes narrow, more narrow. Then he does. Yes, sir. Everybody can contribute also, sir. I am sorry. I am going and talking. I am sorry.
No question, sir. Thank you.
Sir, contribute, sir, some points. At this point, I'll stop. Next symptom, some of my teachers of this girl can discuss, sir. Should I do that or I should discuss?
Please carry on, ma'am. Please carry on.
Ma'am,
Okay.
please carry on. We'll at the end of your discussion, we'll just contribute, ma'am. You please carry on.
Okay, sir. I will quickly go ahead.
Yes.
Okay, next, there is some tingling sensation you told, no?
Yes,
Next symptom is sensory, no?
yes, ma'am.
Yes. What is tingling sensation? And like this, because we are small girls, no? Neurology is mathematics. That is what I want you to know. Unlike other specialities, which needs lot of laboratory data. Neurological diagnosis is made by clinical data because it is anatomy, physiology, some base knowledge, lot of common sense, because the nervous system is spread from the head to the foot. Anywhere you investigate, you will find something. And that is not the cause of the patient's disease. So you will end up treating incidental lesions which you find, which is not the cause of the trouble at all. So keen examination of symptoms correlating with anatomy, physiology, and pathology only will give you the correct result. Anywhere you investigate, something will be there. So that need not be the cause for the patient suffering. So that is why clinical discussion is important. So tingling sensation means what? What term do you use for the tingling sensation? It's a positive sensory symptom. You have got negative sensory symptoms and you have got positive sensory symptoms. Negative symptom is loss. Loss of touch, loss of pain, loss of temperature. So they are all negative. So tingling is a positive sensory symptom. So your patient is having a positive sensory symptom. And positive sensory symptom without a stimuli, it is spontaneous. No? Nobody is touching him, nobody is pricking him. He simply is saying some tingling is there. So spontaneous sensations without any sensory stimuli. What do you call that? So he is getting some sensation. Nobody is touching him. Nobody is pricking him. So that is called as paresthesia. So sensory perception without a sensory stimuli. That is what your patient is experiencing. That is called Paresthesia. Heard of this term?
Yes, ma'am.
Paresthesia. Paresthesia is sensory up. First, you will tell it's a positive sensation. So there is no loss. It's irritation. And what is that? Is it paresthesia, dysesthesia, hyperalgesia? So many things are there. Supposing you have an abscess. Somebody comes near the abscess only, you get severe pain. That is called hyperalgesia. Nobody need to touch also. You come near the abscess, patient will start howling. So that is hyperalgesia. But there is a stimulus. You come near, you bring your finger near to touch, then the patient is howling. But here there is no stimulus. So it is spontaneously some positive sensations are coming. They are called paresthesias. So paresthesias can come due to irritation of some fibers or disinhibition of some fibers, both. So normally, what about sensory transmission in the neuroaxis? When I am undergraduate and all, I always imagine that a good brain means it will gather all information. That's what I have thought as an undergraduate student. Good brain means gather everything. So that is good brain. It is not so. A good brain filters off. So that is the function of the brain. Supposing, now we are here. And my husband called me, like that somebody might call, some wind will flow, no? Some mosquito will flow there. That will come to your visual field. If you start registering all this information, you cannot attend to what you think is your priority. You will be restless. One fly is there, one toy is there, some child is there, no? So you will be attending to everything and become very restless, like a child with attention deficit hyperactivity. So you are not able to attend to one thing. You are hyperactive, trying to attend to everything. So a good brain does not send all the information to the brain. Good brain rejects. It rejects unwanted stimulus. So like that, what happens? You have got a large myelinated sensory fibers, like the A delta fiber. And you have got small myelinated sensory fiber, like the C fiber. No? So these fibers, they filter off. The large myelinated fiber filters off unwanted stimuli. C fiber is a constant dull irritation, whereas quick pain is a protection. You have heard of Lewis double response. You have heard of that in your physiology, Ganong physiology book. There is something called Lewis double response. Supposing you put your finger into the fire, what will you feel? Imagine, close your eyes and think at one point when you are cooking something or boiling, making a cup of coffee, and you try to put your finger on the pan without the proper protection, what will you feel?
We feel burning sensation.
You will feel pain.
Pain.
Next time you go and see, no?
Same.
First you will feel only pain. And after you have removed your finger, slowly the heat will come. The first you don't feel heat, you feel only pain. Because pain is protective. Pain is not having any specific stimuli. Any stimuli, whether it is cold or pressure or heat or beyond the threshold of tolerance, is appreciated at first as a pain only. So you protect your body part. You put an ice piece on your muscle for some 10 minutes. You will feel severe excruciating pain. You just put it for 1 second and take it out, it will be soothing. But you keep it there for some time, it will produce severe pain. So that because that temperature is becoming injurious to your tissues. So any stimulus beyond threshold will be pain. Appreciated as pain only. That is called a double response. What I am telling, sensory transmission is not what is the sensory stimuli doing. It is what you perceive. That is because of several levels of modification. So the large myelinated fiber is protective. Protection is given more importance than understanding the stimuli. Small myelinated fibers carry dull sensations, whereas large myelinated fibers are very fast conducting fibers. They quickly carry the stimuli to the brain and say, this is injurious. Remove your body part. So that is, so large myelinated fiber, which is traveling mainly in the posterior column or in the large myelinated fibers of the peripheral nerve, inhibit the small sensory fibers at the peripheral nerve. That is called sensory modulation. Sensory modulation. For example, you are having your churidar or a dress, sari or something we are wearing. No? But your body is not telling you, you are wearing your sari, you are wearing your churidar. No. But when the dress slightly moves, immediately we will feel it. You see? That is because constant stimuli is not educative. And constant information transfer from your dress is not protective. Unless it produces a painful sensation or it moves away from the normal position, you have to sense it, then only it is appreciated. So that is modulation. So the large myelinated fiber will tell small myelinated fiber, keep quiet, don't irritate and distract. When it is needed, I will send. So it will suppress. So when this suppression is lost, when there is a large myelinated fiber disease, proprioceptive fiber disease, diabetic neuropathy, imagine diabetic neuropathy, no? Then the large myelinated fiber inhibition or the small fiber is lost, constantly the patient is feeling burning paresthesia. So diabetic patients, my feet is burning. Why? The large fiber is destroyed. Small fiber is uninhibited. So it is burning. So paresthesia comes when pain transmission is unmodulated. Stimuli is not there, but internal modulation fails. So the internal filtering off fails. I told no, brain filters off by triaging unwanted stimuli. So large myelinated fiber filters off small myelinated fiber. So this is lost when the large myelinated fiber becomes sick. So you get a spontaneous sensation. So that is paresthesia. And there are multiple levels of filtering. I am sure you have just finished it in your physiology of Ganong. You know the gate control theory of Melsack and Wald. So first level is large myelinated peripheral fiber suppressing the pain and temperature fiber and the C fiber. Next, it enters into the dorsal root. Through the dorsal root, these fibers go up to the spinal cord. No? And when it goes into the spinal cord, there is something called substantia gelatinosa rolandi. Their second level of filtering. So some of them escape and go to the substantia gelatinosa rolandi, unwanted stimuli also. So there one gatekeeper is there. That keeper will tell, go away, we don't want you to go and disturb the precious organ that is the brain. So that is called gate control theory of Melsack and Wald. That's the second level of filtering. Third level of filtering is neurotransmitter based. You have got endorphins and you have got substance P. Endorphin is pro-pain. Endorphin is against pain. And substance P is pro-pain. So these neurotransmitters are modulated so that only the needed pain is transmitted, unneeded pain is not transmitted. That's the third level. Then these fibers go, you just recall your genome pain transmission. No? Then these fibers are sent. You have got the proprioceptive fibers going through the posterior column, spinal thalamic sensation going through the spinal thalamic tract, and then when it ascends, posterior column inhibits the spinal thalamic tract at the tract level. This is what we told nerve level, substantia gelatinosa, transmitter level. Then in the tract level, posterior column inhibits spinal thalamic tract. So surgeons will do dorsal column stimulation for intractable pain. If you have a very badly gangrenous limb, you can do nothing about the person's condition is very poor. Your malignancy is there. You only want him not to suffer from pain. We implant electrodes in the posterior column. So posterior column is stimulated with those electrodes. It will completely stop pain transmission by inhibiting the spinothalamic sensations from ascending. So that is the third or the fourth level of inhibition, normally happening in a modest level. You can increase it for treatment purpose. Very sick patients, In untreatable patients, you only want the pain to go. Then these fibers go up into the thalamo-mesencephalic junction, and they group into thalamic fibers which go into the ventral intermediate lateral nucleus of thalamus, and then goes to the parietal cortex for appreciation of the sensation. Sensory cortex. That will tell you this is a sensation which you have escaped through various filtering and reached the cortex. Next sensation, next is the limbic component. So thalamo-mesencephalic junction, these filtered pain fibers group into three. Thalamic component, subthalamic component, and the limbic component. The limbic component goes to the amygdala and the prefrontal area. So supposing it is your most loving friend who tried to prick you with a needle, then you will feel very sad. But if it is a person who always pricked you, never liked you, that is okay. You will ignore it. But the limbic component is the one which makes the pain more a suffering. Supposing you undergo plastic surgery, suffering is less because the limbic component is a reward system. You feel you are going to look more beautiful, no? So it's a reward system. So the limbic component will be less. So you are very happy. Whereas if it is a friend who purposely, never you expected that the friend will prick you like that. So then the pain is much more. The suffering component of the pain comes from the limbic component. Then what is that subthalamic nucleus? It is a motor nucleus. And subthalamic nucleus goes to the motor cortex. So somebody has pricked you, you cannot give your hand to that person to keep on pricking you. You have to do a motor activity and remove your body part. So for that, the subthalamic component. So understood the pain pathway? No? Understood, no? It is in your Ganong only, so Ganong physiology. So this is unmodulated transmission. So from somewhere that pain modulation did not take place. That is why your patient is getting a tingling sensation. So the tingling sensation can be anywhere in the path through which we traveled right now.
Yes.
So that depends on the distribution of the tingling sensation. We will know whether it is at the level of the nerve. I told in the nerve, A delta fiber inhibits the C fiber. No? So if it is in a nerve distribution, if the tingling is in a nerve distribution, you will know it is a nerve. And if the tingling is in a root distribution, we thought about the roots. The C5 root sensory is outer aspect of the upper arm. C6 is outer aspect of the forearm. C7 is middle finger going on to the elbow in the midline. C8 is medial part of the forearm. D1 is medial part of the upper arm. So if this tingling is in the distribution of any of these roots, we know that the tingling comes from the root level. If it is not a nerve level, not a root level, it is diffuse, then it comes from the tracts. We thought that the posterior column always inhibits the spinothalamic tract. And I told you, dorsal column is stimulated to prevent the spinothalamic transmission in severely painful, terminally ill limbs. It's done like that, no? So if it is diffuse, not in the distribution of a nerve or a root, then it is in the tract. So where is your patient's tingling?
The entire limb, ma'am.
Whole limb.
Yeah, right limb.
Is it in the whole limb?
Yes, ma'am.
Then what does that mean? Which one, which tract inhibits the which tract? Posterior column inhibits the spinothalamic tract. So the next structure involved is probably posterior column. So when the posterior column becomes disinhibited, it becomes sick, the spinothalamic becomes disinhibited. So if it is whole limb, not respecting root or tract, then it is not respecting a nerve or root, it's a tract. So if it's the whole limb, so next thing that is involved is posterior column that is not inhibiting the spinothalamic tract. So patient is developing tingling paresthesia. It is only upper limb or lower limb also?
Lower limb, there was no tingling sensation, ma'am.
Okay. So anyway, history we have to see because roots or whatever pattern when we examine, we will see from the history if it's the whole upper limb, you have to put it as a tract pain. Posterior column is involved and spina thalamic is uninhibited. Next. Then you develop weakness of the right lower limb. How do you get the weakness of the right lower limb? I told that medial pyramidal fibers is infarction. But next by the tumor or disc or whatever is situated, it keeps on increasing the compression. Little laterally placed corticospinal tract is the lower limb fibers. That is the mechanism of Ellsberg. It starts with infarction. Then by expansion of the lesion, knocks off the outerly placed lower limb fibers. Then contra coup. So it's an eccentrically placed compression. It's not a central compression. Only eccentrically placed compression will start with monoparesis. Then it will push the spinal cord to the opposite side, but because it's a laterally placed compression on the right side, which sat on the mouth of the sulcocommissural artery. So medial pyramidal got involved. Then the lateral pyramidal got involved by expansion of the lesion on that side, complete corticospinal tract involvement. Then because it is eccentrically placed, it pushes the spinal cord to the opposite side. When it is pushed, opposite outer part is leg area. Inner part only arm area. So the leg area of the opposite side gets involved first. So it's opposite lower limb. Then by completion of compression, opposite upper limb also gets involved. That is the mechanism of Ellsberg phenomenon. So it is expansion of whatever is causing the pathology, the lower limb fibers which are outer getting involved, that will produce the lower limb weakness. Just understand in your level now, you should know what is GM, what is element. Then what is this distribution of nerves and roads? What are these symptoms meaning to you? So those basic understanding is sufficient. So now it looks like evolving Ellsberg. Started in one upper limb, went on to the ipsilateral lower limb. So it looks like an evolving Ellsberg phenomenon at this point of time. The next, he developed slipping of footwear while walking since 4 months. And he was aware about it. What does that indicate? It is due to motor weakness. So in this case, this motor weakness, you want to know whether it is LMN or EMN. How you will know? Slipping of chapels. Motor weakness can be, because upper limb looked like a EMN. So you want to know whether it is EMN type or LMN type. In LMN type, it is the intraosteal muscles. So putting your feet in the chapel is easy because the space between the toes is more. When the intraosteal are weak, the toes are separated. So easily you can put your feet into the shoe or chapel, whatever it is. But you cannot hold on and walk because you cannot bring the toes together. So it will slip. So putting on is easy. Holding on and walking is difficult. Removing is easy. The space is more, so you can easily remove. Whereas if it is upper motor neuron, I told you that it is the kinetic melody. Fine coordination of movement that is impaired. So putting on will be difficult, holding on and walking will be difficult, and removing will also be difficult. Because all these movements need fine coordination of agonist, antagonist, synergist, fixator. You have seen, read about that, no? Agonist is the structure that is doing the activity. Antagonist is the one which permits this to do and inhibits the opposite action. When you want to flex your hand, your extension should be inhibited. So during this moment, agonist is flexors, antagonist is extensor. Agonist is facilitated, antagonist is inhibited. Synergist and fixators are adductors and abductors, which coordinate that movement without opposing or facilitating. They are synergist and fixator. So this coordination between agonist, antagonist, synergist and fixator is by upper motor neuron. That is there in every step. So you cannot put your feet into the chapel. You cannot hold on and walk. When removing also, one finger will try to override because sometimes antagonist will be activated. You see? That is pyramidal disc. So all 3 steps are affected. It is upper motor neuron. Only one step, that is holding on in walking, is affected. It is lower motor neuron. So that history you can ask if you say. And he is dragging the foot. No? He is dragging the foot with high stepping or no high stepping. Suppose you have foot drop due to some lower motor neuron problem, patient will drag with the toes hitting the floor first because of the foot drop. If it is a spastic limb, they still drag with some degree of circumduction, stiff dragging. So that dragging happens due to upper motor neuron disease, means it's not high stepping. It will be dragging with slight alteration in the semiology of the gait. The gait here also becomes toe first. That is called pyramidal foot drop. But pyramidal foot drop will be not like the LMN foot drop. So that you can ask, is dragging with the high stepping or dragging without high stepping? These are learning points. You see, as an undergraduate, you should learn this basic thing thoroughly. Then the mistakes will be less. As I told, no, you do nerve biopsy for a patient with a brain tumor, that will show something. Because anybody who is 60 years, he might have some nutritional deficiency. He may be using tight shoes. No? He might have sat with crossed legs, or he may have diabetes. Then the nerve biopsy will show some result. But he is not suffering from neuropathy. He is suffering from brain tumor. So unless you thoroughly localize, any part you investigate, there will be something. That will not be the disease of the patient. So that is why you do like this. So that is what you should be asking. Was he having a stiff circumducting gait, slightly toe first, not high stepping? That means it is human. High stepping, because of the high stepping, he is lifting the foot, not circumducting. That is element. Okay.
Okay.
And he is requiring support to get up from squatting position. Okay. So that also can be human or element, you know that. So human means he is stiff, because of that he is unable to get up. So in the early stages, he will hold on to the side rails and get up. When it is late, somebody will have to pull him up, because it is not the semiology of getting up that is affected. It is the stiffness that is preventing from getting up. Whereas in muscle weakness, some of the muscles are paralyzed. So patient will alter the gait, alter the way he is getting up. Hip extents are weak or not able to get up, means what the patient will do, he will use the spine extensor, erector spine. Erector spine is attached to the iliac crest. So that erector spine attached to the iliac crest will be used to get up. So the erector spine cannot erect the spine and pull the leg also. So the proximal part, upper part of the erector spine will be knocked out. So patient will bend, hip will go up. So the way you get up will be different, with the pelvis going up and the trunk bent, if it is element weakness. If it is stiffness, the semiology doesn't change. The tone prevents him from getting up. So somebody will have to pull him up if it is severe spasticity. So those points will help us to know in the history. Your history is excellent, very good for your level. I think at your age, I did not take proper history. Now I am old, retired, 4 years. So it's a different thing. But I am telling you, this is how you should understand, no?
Yes.
What is happening to your patient by appropriate questions. So has the semiology changed? Is he bending while getting up? Is he putting his pelvis up? We can never imitate that, because we can never get up with the pelvis up when your hip extensor is normal. Or is he stiff? That gives us clue in the history. At the end, you will be happy your diagnosis was correct because of the correct history taken. So instead, getting up from the sitting posture can be due to knee pain also. You see, you may have knee pain, you may have corn foot. All this will interfere. So you have to elaborate and find out what exactly is disabling him. Then we will know if this is neurological or not neurological. And if it is neurological, is it LMN or EMN or both? So that is how you should design your question. My patient has no knee pain. He is not having any angle edema. He is not having any other painful difficulties not there. That is more common in this age group when degeneration is there. No? So it's not a painful weakness. It's not the pain that is interfering. The semiology is not changed. my patient is feeling stiff, so he is unable to get up. If you say that, so you have to ask, they won't tell, they don't know. No? So you have to put, you have to elaborate the history, so they will give you the information. So no transmission, no step for. Okay, next positive symptom go. Now neck pain. Dull aching, not radiating. Dull aching pain in the neck come from what are structures? Dull aching pain doesn't come from the roots. Your patient is having some problem in and around the neck, probably because his one upper limb and ipsilateral lower limb is already weak. So is the nearby roots are getting involved at that level. So root pains are sharp pains, very sharp. They are shock-like. They are in the distribution of the roots. And they have aggravating factor and relieving factor, coughing, sneezing, weightlifting, putting weight on the head. That will produce a very sharp, shock-like pain along the distribution of the root. That's a root pain. So it's not a root pain. So dull aching pain in the neck can be coming from the muscles. It can come from the periosteum. And it can come from the various small and big joints of the vertebra. So they are spondylotic changes. They will say neck pain. You don't find any signs when you X-ray. You find some osteophytes. No? So that's it's not a root pain. Dull aching pain is not a root pain. It can come from the muscles. It can come from the periosteum. It can come from the vertebra. So any of them or all of them may be causing the dull aching pain. It's not radiating. It is not sharp. So it is coming either from the muscles or from the periosteum or from the vertebra. So that's a dull aching pain. Okay, go on. So now we are developing tingling sensation in the left upper limb since 1 week. In the left upper limb, what is the distribution? Is it the whole upper limb or?
No, only the left hand. Palm region he had weakness and tingling was present only in the fingers, ma'am.
In the palm region.
Yes, ma'am.
So in the palm region alone means again whole of the palm. The whole of the palm pain cannot be in the root because we saw C5, C6, C7, C8, D1. So if you take palm, it is C6, C7, C8. So many roots. It's not having a radicular quality. So whether that palm pain is also coming from the crossing spinothalamic tract at that level. Whether that is also ischemic, we don't know. Because then only you can explain that. All, because it is more than one root and radicular quality is not there. You did not have any sharp pain. So it cannot be multiple roots. So we call it as coalescing root. Coalescing root will have radicular quality. It's a sharp, shock-like pain with specific aggravating and relieving factor. That's not there. You are getting a constant pain in this distal part of the palm. Then it may be the crossing spinothalamic. They are arranged together in that segment, in one segment. So whether it is another sulcocommunicable artery, that's a possibility. Okay, because it doesn't fit into one nerve or one root. You see, C6 means this much. Forearm also. C7 means like this. C8 even like this. So not this much. So this may be again another ischemic level. That is a more possible. When you now, I have put one class on spinal cord also in the vitamin. You can read that. No? You will understand that localization. So how common sense only we are using. No? Now we are applying common sense to say that with this symptom, if the history is correct, if the patient does not give a proper history, we will be wrong. So if the history is correct, this hand alone is not possible with the root. It can be post-central gyrus in the cortex, where the hand area is there. Or it can be a spinothalamic crossing fibers only. Now already we are thinking it is an elsewhere. Then it may be multiple ischemic levels. Multiple sulcocommunicable arteries may be getting involved. The pseudo-syringomyelia I told, no? Where the crossing spinothalamic gets involved. That's a possibility. Or when you examine, you find only cortical sensations are affected. He is a hypertensive. So has he developed a lacune in the post-central gyrus? That's also possible. No? Then examination, cortical sensation will go, other sensations will be preserved. Whereas if it is sulcocommissural artery, cortical sensation you cannot test because other sensations are the ones which are lost. When other sensations are impaired or lost, cortical sensation you should not check. Like that. Next. Okay, so all list is negative symptoms. No? So now you are having a patient who is having a motor weakness in a hemiplegic distribution. One upper limb and one lower limb. And sensory in a whole of the right upper limb, spinothalamic tract, we thought it could be. And both sides, it looks like a tract. So, what are the things you now think in an asymmetrical spine, asymmetrical syndrome, which we think it could be spinal cord because there is additional neck pain is there. And we did not have any altered sensorium. We never had any seizures. Cortical features were not there. And opposite upper limb is also getting involved before involving any cranial nerve. So in and around the neck, it seems to be getting involved. Neck pain is there. One hemiplegic pattern, then go in the opposite side. And there is nothing else above getting involved. So even though we thought about cortical monoparesis and all to start with at 6 months before when the patient came to us, now with the neck pain and this kind of pattern without involving any cortical structures, even when the opposite side is involved, then you have to think of both sides of the hemisphere. Cortical lesion means both sides of the hemisphere, theoretical possibility. Doesn't happen normally. One side of the motor strip, one side of the sensory strip, and opposite sensory strip, that's only theoretical lesions. Every lesion, if possible, explained by one side. So if you want to explain by one side, it looks like a spinal cord for the following reasons. My patient has got a hemiplegia without cranial nerve palsy, and his sensations are not in a pattern of MC or ACA distribution, but it apparently appears in a tract distribution, and the opposite side looks like a crossing spinothalamic. So this could be a spinal cord. Next, you said some bladder, that will come to. So supposing one side ipsilateral corticospinal, opposite side corticospinal is not there. What do you call that?
Opposite side is also there.
Which one?
Opposite side is also there.
Weakness is there.
Weakness and tingling sensation of the left.
Tingling sensation you told.
Yes.
If weakness is not there, what do you call that? One hemiplegic pattern, when you examine, you find, of course, opposite side, some finding is called Brown-Sequard syndrome. No, spinal hemiplegias. We call it as Brown-Sequard syndrome. Then when you carefully examine, you will find that pyramidal deficit on one side, posterior column on the same side, spinothalamic on the opposite side. That is called Brown-Sequard syndrome. So it looks like an atypical Brown-Sequard syndrome, not the classical Brown-Sequard syndrome where patient will have symptomatic posterior column and pyramidal on one side. That seems to be there. And opposite side whole, not one upper limb, spinothalamic, not the crossing spinothalamic. It's a hemispinothalamic on the opposite side. That is Brown-Sequard syndrome. So is it an atypical Brown-Sequard syndrome at this point of time? So it's an eccentric cord pathology. So it looks like a atypical Brown-Sequard syndrome at this point. Keep this in mind and examine and check for the posterior column. Is it symmetrically involved or asymmetrically involved? All those things we should do when you are examining. Next, you said that your patient developed some bladder sensation, no?
Yes, ma'am.
So what is that bladder?
He had
You
interrupted
said
flow.
dribbling bladder.
Dribbling.
So what do you mean by that?
Was
Dribbling means, why did you say dribbling? Dribbling is an interpretation, no? So why do you say your patient is dribbling? Why did you say that? Is he continuously wetting his clothes?
no, ma'am.
Then it is not dribbling. You see, a dribbling bladder is A person who is continuously wetting his clothes.
Okay.
If he is not continuously wetting his clothes, you don't call it as dribbling. So what, describe his bladder problem. What is his bladder problem?
He told it was like the stream would be very slow. Like it is not
Stream
going.
is slow.
Yes, ma'am.
So what situation you get a low stream? So is it part of the spinal cord or something else? So what situation you get a thin stream?
It can
Thin
happen in
stream.
prostatomegaly.
Which one?
Prostatomegaly because
Good,
of
very good, very good. So thin stream is not neurological.
Okay.
Thin stream is obstructive uropathy.
Yes.
Thin stream is not a dribbling urine. Dribbling urine is continuously dribbling.
Yes.
So thin stream means urine is being squeezed through narrow structures. It can be a stricture urethra or it can be a prostatic obstruction or something like that. That only produces thin stream. Whereas in a spinal cord disease, at this level, what do you expect? Automatic bladder.
Yes.
So cervical spinal cord producing a bladder, because that also it recognizes, because this patient's bladder symptom may not be due to this. It may be due to an easily treatable prostatic enlargement. So he should undergo investigation for that. So in a spinal cord compression, you get an automatic bladder. If this disease, which looks like a brown sick cord, has spread slowly to involve both sides of the cord, then you expect an automatic bladder. It is an incomplete lesion, patient is still ambulant, he is not bedbound. So incomplete automatic bladder, patient will partly or completely have impaired sensation of fullness. So fullness may be partly or completely impaired. He may or may not appreciate, depending on the completeness of the pathology in the spinal cord. He will have either precipitancy, hesitancy, or automatic emptying. Precipitancy, incomplete bladders, when he wants to go to the toilet, on the way only he will pass urine. That is called precipitancy. That is due to more compressive effect on the inhibitory fibers. You know, from the cortex, there are inhibitory fibers and facilitatory fibers. I'm not going to that. I have put one session on the bladder also that you can read, because that's another topic by itself. No? So partial compressions, inhibitory fiber is gone means patient will hesitate. He gets the blood sensation, goes to the toilet, but he has to strain. And once he strains, a large amount of urine will pass. That is called hesitancy. Hesitancy can happen in obstructive uropathy also. Next is precipitancy. He gets the sensation before reaching the toilet, he passes the urine. That is if the inhibitory fibers are gone, he is precipitancy. Automatic bladder is complete spinal cord compression. So there is patient is not appreciating any fullness or pain. Once the urine amount secreted is more than 300 to 400 ml, automatically bladder starts contracting. So patient will pass out that 300 ml and he cannot stop his urine on his own. At the end of 300 ml emptying, it will stop on its own with a large residual urine. So not appreciating fullness or pain, not having any control over micturition. Micturition starts on its own when the urine accumulated is more than 300 to 400 ml and it empties that amount and then stops. That is automatic bladder. So these are the three bladders we expect in this patient. Either a partial bladder where precipitancy, hesitancy, or automatic bladder. Dribbling is not expected. Dribbling is expected in cardiac vena syndromes, neurologically. Otherwise, dribbling bladder happens in urological cause when there is a fistula. Otherwise, dribbling is not expected. Here you are, it's not dribbling also. It's not dribbling also. It's only a thin stream. So keep it in mind. If it is thin strip, you will evaluate for a prostate.
Okay.
Okay, next. When you describe your bladder, you should always ask, is he appreciating fullness? And if he goes beyond the period of fullness, is it becoming painful? Can he voluntarily start emptying? When he goes to empty, has he to strain? Or before reaching the toilet, is it coming out? Is he emptying good amount of urine or less amount of urine? At the end of emptying, does he feel like still urine is inside? That is called a large residual urine, otherwise called double voiding. And because of this residual urine, patient can feel like dribbling, post-voiding dribbling. So after you have emptied some 300 ml, some few drops wet your cloth. That is called post-voiding dribbling. That indicates residual urine. So this much you should ask for any bladder symptoms. Thin stream, intermittent stream, hematuria, dysuria. So dysuria, hematuria, intermittent stream, and thin stream is obstructed. Okay, go on. So apparently it looks at the end of your history like a typical Brown-Sequard syndrome. And probably the bladder has to be, bladder's history we have to re-ask what exactly he means by thin stream. And is it really a thin stream? Or is it incomplete emptying? All those things you will have to ask. Okay. Then examine. After examination, your sir can discuss, I think so. Okay. Go on.
On general physical examination, the 60-year-old male was conscious, cooperative, well-oriented, time-placing person. He was moderately built and nourished. He was sitting comfortably on bed and pulse rate was 86 beats per minute. Measured in the right radial artery, regular rhythm, normal character, adequate volume, and elastic reservoir. His blood pressure was 110 by 74 millimeters of mercury, measured in right brachial artery in sitting position. And respiratory rate was 20 cycles per minute, which was abdominal thoracic in sitting position. And temperature was 98°F, measured in the left axilla. Pallidity, cyanosis, clubbing, lymphadenopathy, edema were absent. And on head-to-toe examination, there was redness in the left eye because of trauma, and lower limb had a scar. Everything else was normal. CNS examination, he was a right-handed person, and he was conscious, cooperative, well-oriented, time-placing person, and he was appropriately dressed and maintains personal hygiene. And the mood of the subject is normal, and he has recent memory of recent activities, and his language and speech is normal, and his MMSE score is 30. All the cranial nerve examination was normal except his left eye, which had severe blurring due to trauma.
Left eye, he has blurring of vision.
Yes, ma'am.
Does he have any local ophthalmological cause?
Yeah, local, ma'am, because he had gotten hit when he was a child.
Okay.
Sensory system, vibration sense was decreased in both right and left of upper and lower limbs. Ma'am.
So vibration is carried by which tract?
Posterior column. Ma'am.
Posterior column. We clinically only thought there is posterior column involvement. We thought no.
Yes, ma'am. And Morta's bulk was, there was no atrophy seen. Both the bilateral right and left sides were equal. And tone of muscle, according to modified Asheville scale, arm and forearm bilaterally had 2, and lower limb had 3, ma'am. And power, neck muscles were 5 by 5, and trunk muscles, he needed support to sit straight from recumbent position. And shoulder, it was normal. Elbow on the right side was 4 by 5, and wrist on the right side was 3 by 5, and fingers, it was 3 by 5 on the right and 4 by 5 on the left. Hip was normal, and knee was also normal on both sides. Ankle was 4 by 5 on the right, and toes was 3 by 5 on the right side. Superficial reflexes, corneal and conjunctival reflexes were present, and plantar Babinski was positive. And deep tendon reflexes, everything, biceps supinator, triceps, knee, and ankle jerks were exaggerated except his left ankle jerk because of the scar. And Hoffman's sign was positive. Here is a demonstration of Hoffman's sign. And cerebellar system, dysmetria was present on the right side, and dysdiagonal was absent, nystagmus is absent. And heel to shin test, he could not perform on both right and left side. And he had spastic gait. Ramberg's test was positive. Tandem walking he could not perform, and there was no involuntary movements. Lermite sign was negative, and tonus was absent, and no signs of meningeal irritation. Systemic examination, serious S1, S2 heard and no murmurs. RS is normal vesicular breath sounds heard and no added sounds, and abdomen was soft, non-tender, and no organomegaly.
That's okay, Eakaika. Just get back to the examination, no?
Yes.
Get back from the first slide. Yeah, no. Come back. Yeah, front. Start with CNS examination. This is fine. Next, cranial nerve examination. Can you just see one of the few things ma'am has explained as well as made you all people understand very well how to take a proper history and what each symptom and each question, what it means and how it helps in localization. Madam has told that quite detailed. What there's few things which I wanted to tell you that see handedness has to come even in history also. You're told that in an examination, that is correct. But from when you take personal details, no, when you have when you speak about handedness that time only, it gives you already you have your first step into localization will start from there when you know what the handedness from there. Okay. The another thing is what as madam said, I would like to stress upon. You need to know about fine and gross motor movements. The fine motor movements are controlled mainly by your cerebrum as well as corticospinal tract. So whenever you have a problem in your cortex, subcortical, more chances of you getting symptoms involving the fine motor movements are more, whereas rather than a gross motor. But when your gross motor is involved, there are two things which you have to know. One, you have to see whether if a lower motor nerve involvement is there, or most importantly, you have to see also if there are any extrapyramidal symptoms with that. Because for tone, for the patient to stand and posture and everything of the axial, that is the proximal muscles, is mainly controlled by your extrapyramidal things. Okay. The other thing is, you mentioned something about the giving way sensation when the patient was not able to walk fast, and there was, when he was walking, there was giving way sensation in the knee. So that is one of the things which points out towards spasticity. Everything else, madam has equally covered. So about the coordination and everything. So can you just tell me how you do test for olfactory nerve? Because that is more important for you rather than big things. How do you check for olfactory nerve testing? How did you check?
So we close one of the nostrils and tell them to inhale odorous substance.
What are the things which you used?
Like there's cardamom or any spices, sir.
Any? Sorry?
Spices or perfume.
See, one of the most important things you need to understand. See, you use basic things like coffee and all those things.
Yes,
but the one thing we should not do is use any pungent odor. Okay, you should never use a pungent odor because that causes irritation of your olfactory nerve. Then your testing might become problematic. Okay, that is fine. Next, optic nerve, what all you tested?
Optic nerve, we tested for vision acuity, sir.
Using?
Vision acuity.
Yeah, I don't know. Using what? How did you check it? No, you written 6x6, no?
Yes, sir.
So where did you get that 6x6 now? You use the Snellen's chart, okay?
Yes, sir.
That is how you have to use a Snellen's chart to document your visual acuity. I know you might have remember, but now you're forgetting. That's why you're smiling.
Yes.
So because in your examination, these are the small things they'll ask. They'll not see you are just a final year student. You will be giving your examination. If you are getting a neurological case, the most probably you will get a stroke case. So they are not going to expect big things from you. Well, these small things you should not miss. Okay. That is correct. Then your colors. What are the color charts called? Ishihara charts. Yes, correct. Okay. Then next thing is your oculomotor nerve. What all you have explained? You have explained that the pupils are round, regular, central, equal on both sides. Correct? Next, your pupillary reflex and accommodation reflex. How do you check your pupillary reflex?
So we bring the dots from side to the center and see if there is contraction in the same side and on the opposite side, both the sides.
So opposite side, what is it called?
Uh,
What is that reflex called when you shine the eye to right eye? If there is a left eye contraction, what is it called? You're correct. But there is one specific term. This term is consensual reflex.
yes.
Okay, this is the direct reflex. When you, which eye you're testing is the direct reflex. The other side is the consensual reflex. Next, one thing what you have missed here is the ocular and obtrucent. You have checked the motor eye movements, but oculomotor also supplies no eye movements.
Yes.
That one you will have to mention. I know you would have checked, but that you have to mention. Next comes your trigeminal nerve. Trigeminal nerve, you have spoken about your corneal reflexes, sensation of your present, and motor function. As in, what have you tested for motor function of the trigeminal nerve? What is the motor function of the trigeminal nerve? See, I wouldn't have asked you this question if you had not written. Because I understand that this part is a bit sophisticated for you. It is not at the level of fine there. But you will still remember from your anatomy.
I could not hear you, sir.
Mastication, lateral masseter muscle, pterygoid muscles, the
Yes.
pterygoid muscles. There is a lateral and medial pterygoid muscle.
Yes.
Correct?
Yes.
What is the supply of nerve supply of the lateral and medial pterygoid muscles?
Trigeminal.
Yes, correct. It is a trigeminal nerve. So muscles of mastications are tested for your motor function of your trigeminal nerve. Take next slide, please. Next comes your seventh nerve. So seventh nerve is important. We have actually seen it proper. You have written that space. You see. So upper motor neuron, lower motor neuron. Since madam has spoken to you in detail about upper motor neuron lesion and lower motor neuron lesion, even in a facial nerve, as it is a nerve, there is a nucleus. There is a nucleus in the brainstem. So there is, from the nucleus below your nerve is your lower motor neuron, and then your above that is your upper motor neuron. So what you need to understand in the facial nerve examination is, if any case, for example, you have a facial nerve palsy and you have weakness of one side of your face. If in that case, the whole of your face is paralyzed, it is most probably a lower motor nerve. But if only your lower part of your face is paralyzed and your upper part, that is your face, that is your eyebrows, as well as wrinkling of your forehead, are present, both the sides, then it is most probably an upper motor neuron lesion. Why? Because the upper face is represented on both sides of the cortex. So even if one side of your cortical or subcortical level there is a lesion or a problem, or for any cause, that is, your opposite side is still there because of your bilateral representation of that upper face. So hence, that is the differentiation between a UMN facial palsy and an LMN facial palsy. Okay, and it's a bit difficult for you to remember all these things. But if you listen to this once, it will be stored somewhere. That's the beauty of the brain. It will be stored somewhere. So when you revise, and if someone wants to go ahead and pursue a career in neurology, it will always come back. Okay. Next is a vestibulocochlear nerve. Vestibulocochlear nerve, hearing is normal. Correct. You have examined your hearing. How do you examine your hearing?
The NIMHANS test, Weber's test.
That's the tuning fork test. So before you do a tuning fork test, you always ask roughly the patient. You just roughly, with a rub test, you see whether he's able to hear or not. Then you go ahead and go to your tuning fork test. That is your Rene's, Weber's, and at least minimum Schwab test. Okay, or absolute bone conduction, one of those. But you have not mentioned anything about the vestibular part here. How do you like, what happens if you have a vestibular problem?
Nystagmus.
Nystagmus. Correct. Nystagmus is correct. Any other thing? Basically, they'll have balance issues. So nystagmus you have to mention here, and the balance issues. I know there are various tests for vestibular nerve, but they are not for an MBBS graduate for you to understand. Next is your glossopharyngeal nerve. Gag, reflex, sensation over your pharynx, all those things. How did you test that? How did you test your gag reflex? Because the examiner might ask you how you are testing, or he might tell you to demonstrate and show you in your practical examination. So how did you check for your gag reflex?
I asked the patient himself to put fingers inside his mouth.
No,
Posterior.
that is the no, that is very wrong.
Oh.
What you need to have, you should always have a swab.
Okay.
Because see, you will have a stick to depress your tongue. You should have one more swab. So under your under guidance, you should stimulate your posterior pharyngeal wall with your swab and check if he has a gag. Like how you have two both sides. Okay, right side and the left side. Two of the nerves, right? So right side and left side. So that is how you check for a gag reflex. Understand? Because testing taste sensation in a posterior third is actually difficult. It is easier to check gag reflex and come to a conclusion of whether your glossopharyngeal as well as some part of vagus, because vagus is also the fibers which supply the sensation towards the posterior pharyngeal wall. So that is more easier when compared to checking your posterior sensation taste. Okay. Next comes your vagus nerve. What did you check? Uvula. How did you check your uvula?
You can do galvanic stimulation also for posterior tongue sensation.
Yes, that also can be done. True, sir. So, how did you check your vagus nerve, your uvula?
We told them to tell sir.
And what did you observe?
It did not deviate to the right.
Okay. So here what you need to understand is there are two things you have to see. One, you have to see uvula, correct. What you told is absolutely right, that it is centrally placed. And when you put into action, when you told the patient to tell you saw whether it is moving on to one side or not. So with uvula, also you have to observe the pillars which are there in front of your tonsils to see if they are taut or sagging. Okay, because the tone is maintained by the vagus nerve. Understood? Why I have written voice is normal? What is the significance of what you have written? Voice is normal. What is the significance of that?
Vocal cords.
The vocal cord is supplied by laryngeal or recurrent laryngeal. This is your anatomy. This is all your anatomy. Your written, what you have written is correct, but it is because of your recurrent laryngeal nerve. True? Okay. Next, your spinal accessory. How did you check for your sternocleidomastoid?
Told him to turn his face against resistance.
So, for example, you have told the patient to turn towards right, and you are giving the resistance. So, which side sternocleidomastoid are you testing?
The opposite side.
You're doing which side? No, I'm giving you a particular scenario. You're telling the patient to turn towards right and telling him and giving him resistance on the right side. So you're checking on the right side or the left side?
Sir, the opposite side, left side.
And how did you check for your trapezius?
Sir, elevation of shoulders against resistance.
Okay. Next comes your hypoglossal. So hypoglossal, you told tongue is central, and can it move and out? Okay, that is also correct. So what another point which is for everyone is that if there is a hypoglossal palsy of your right side, okay, which side does the tongue deviate to?
To the right side only. No, to the left. To the left side.
Decide. Which side?
To the left, I think.
Okay, well, I'll make it a bit simpler. For example, you have a facial nerve palsy of the right side. Okay, which side is the deviation of the tongue or deviation of your face?
Left side.
Why?
Because there's unopposed contraction of the muscles.
So apply the same logic here. Hypoglossal nerve, the right side.
I cannot hear you, sir.
Hello?
Huh.
Am I audible?
Yes, sir. Yes, sir.
See, right side you have your hypoglossal nerve palsy, correct? You're protruding now. Which side is active? Which side muscle is active?
Left side.
Left side. So which side will the tongue, the muscle push the two words?
Left side. Sir.
How can it be left side? You're protruding. This is action.
Yes.
So this side is faulty. So it goes like this.
Okay, okay, sir.
That protrusion action you have to think of.
Okay.
Okay. There is a rule of 17, an easier way to remember mnemonic. Okay. Hypoglossal is 12th now, correct?
Yes.
Trigeminal is 5th now. So 12 plus 5 is 17. Okay. 10th nerve is vagus, correct?
Yes, sir.
7th nerve is facial. 10 plus 7 is 17.
Yes.
So 12 plus 5 is equal to 10 plus 7. That is 17 into 17. That is in 7th nerve and 10th nerve, the deviation is towards the opposite side. And 12th and the 5th nerve, the deviation is towards the same side. Okay. Next slide. So coming to your sensory symptom. Okay. In a sensory system, the only positive you have is vibration. So what was the frequency of tuning fork you use for testing vibration?
Sir, I used 512.
Sorry?
512 hertz.
Yeah, 512 is not ideal to be used. Okay. You
Okay.
have to use, see, when you're going to exam, they will always tell you to carry tuning forks, at least 3, which are those 128, 256, and 512. But in this, at least 2 you should have. That is your 128 and 512. Because 512 you will use for hearing and 126 you will use for
Vibration.
128 you will use for
Vibration.
yes, exactly. Okay. So for this, the most important thing you need to learn is about your dermatomes. That is, as madam has already told you about your upper limb dermatomes, where C5 comes, T6, T7, T8, and T1.
Yes.
T7, T8, and T1. Sorry. Like that only for lower limbs and for upper limbs also, you have to have some landmarks of your dermatomes. Okay. So do you know any landmarks for the dermatomes? Like for example, what is the dermatome at the level of nipple?
T3 or T4?
T4. Yes, you are correct. T4. You're absolutely correct. Okay. T4 is your nipple. Your umbilicus is T10. So umbilicus is T10. Inguinal region is L1. So in the lower limb also, like in upper limb, it comes L1, L2, L3. Then your L4 comes to your knee and your medial aspect. L5 on your lateral aspect. And S1 is very significant because it's in the lateral border of your foot. Your L5 is come from the lateral towards your foot on the dorsal aspect, not on the plantar aspect, on the dorsal aspect, especially your webbings, except for your last lateral border. The lateral border is basically a S1 representation. So this dermatomes you should know when you're checking their sensory system, and you should all know how to check your reflexes and your sensory system. So in your sensory system, for example, here you have talked about stereognosis. What is stereognosis and how did you check? Stereognosis is a cortical sensation. It is not a sensation, regular sensation as such. So how do you check for stereognosis? Do you know? No. It is there in the name itself. What do you think It might be. It's a tactile object recognition. Remember this word.
Yes.
It's a tactile object recognition test. So what you do is, you tell the patient to close his eyes, and very familiar objects like a coin, a ball, a cube, you give them in the hand, close with their eyes closed, and tell them, please recognize what it is. Okay, this is important when the patient has an infarct in the cortical level or a subcortical level, where in the sensory area, where the issue can happen, where the cortical sensation is lost. That is what is called, because I know that fine touch, crude touch, pressure, vibration, and all you would have checked properly. I know that. That's why I'm giving more impetus onto these tests, that is stereognosis, proprioception, because they are a bit tricky to be tested. So where did you check your proprioception?
Sir, joints,
Which joints?
finger joints, elbow joints.
Yes, you're absolutely right. You're absolutely correct. So how do you check is, see, one of the most important things we should understand is, when you're checking for proprioception, even the touch is also being sensed by the patient, correct? It's not that only proprioception is being touched. For example, if you're holding the finger, okay, can you see? You're holding the finger like this. You're moving the finger. So if I'm moving the finger, I'm also activating the touch receptors. So the chances that if you hold like this, that is, here is, for example, I'm testing this interphalangeal joint. So if I hold like this and push it down, my body will recognize that the upper aspect is putting more pressure. So because of the touch also, he might recognize that, okay, no, my finger is down. And he might tell you that, oh, but then you would have lost the proprioception examination there. So always what you do is, if this joint, you're be parallel to the joint. And then, see, if you move this way, the touch is there, but is equal on both the sides. He cannot tell it is up, the joint is up or down. Understand?
Yes.
That is how we check for proprioception. Temperature, you check well and good. Next, the bulk. So the bulk here is not that different. Why do you think? Even though the patient has weakness for almost 5-6 months, like he has one upper limb weakness which started about 6 months, then the lower limb weakness which started about 5 months. Even after such prolonged weakness, why do you think the patient's muscle bulk is still preserved? How do you think it is still preserved?
Because it is a human lesion.
Yes, you're absolutely right. Yeah, very good. As madam said, in an LMN palsy, there is significant LMN lesion. There is significant atrophy of the muscles, wasting of the muscles. Whereas it can happen even in UMN, but that is called a disuse atrophy. Madam said it's a hypoplasia. So due to prolonged, if the patient is, as for example, patient has hemiplegia, that is complete loss of power on one side. The patient is not using that limb and he's neglected, not physiotherapy is not done, rehabilitation is no process is not done because of prolonged. So that's called a disuse atrophy. That is your difference between disuse atrophy versus a wasting, which is there in your element. Another thing which you have to note is, when you start your motor system after your bulk, go to next slide. Before you write tone, you have to always mention if there were any fasciculations which were seen, because fasciculations is an integral part of a element palsy, element type lesion. So observe, just let the limb rest and just see the limb and tell whether there are any fasciculations noted or not. Always try to see fasciculations where the muscle bulk is more. It will be easier to see. If you go to see in the hands, where the small muscles of hands are there, and it tells her no fasciculations, I'm not able to see, it will be a bit difficult. You might see. Nothing is absolute in medicine. You might still see. But checking that in a bulkier muscle is always easier. There's one more thing. when you tell, you can also add something called the attitude of the limb. Okay, that is, if you're telling for the lower limb, it's extended, flexed, it is externally rotated, internally rotated, or in a neutral position. All those things matter. How? Because if there is a patient has a weakness, severe weakness, element palsy or hip weakness and everything, the patient's tone is lost in element. So it will be external rotated. He'll just fall on the bed. That also gives a clue. Okay, the patient most probably the patient limb is weak. Then you check, telling that how the weakness is, you can attribute it to human or to the element. Another thing is your flexion or any deformities are there. Patient can have severe spasticity, or even for disuse atrophy, the patient can undergo contracture of the muscles. So there will be in upper limb, it can be in this position, and your fingers are contracted. So you know that the disease has been there for a longer time. Chronic disease, rather than an insidious or an acute disease. When the attitude of the limb is like that, tone. So can you just explain to everyone your right upper limb arm tone is your written as 2 according to the modified Ashworth. Please tell me, what does that mean?
There is more resistance while moving his arm passively. During the range of motion, there was more resistance than usual.
Yeah. But still, the affected part was still, you were able to move it. And you are written 3, correct? So what is 3? What did you notice in 3?
So it was significant increase, sir.
Yeah, the most important difference is considerable increase. You are correct.
Yes.
But the most important thing is a passive movement is difficult. Okay. So when you're checking for your tone, it is the, what is the tone? What is the definition of the tone, if you can remember from your physiology?
Sir, it is a slight resistance of the muscle when moved in rest, sir, like passive movement.
Yes, that is important. Okay.
Yes.
The most important word in that is the tension or the resistance which you feel when you are passively stretching. That is when the muscle is at the rest. So for example, when you're checking, you keep your hand this way and you move. You move it. You don't tell the patient to move. You move it itself. So when do you think? So for example, when I'm flexing, this is your biceps brachii muscle as well as the other muscles which are there, which are helping to flex. So do you think when I'm flexing, I should be checking this muscle group? Yes, no?
No, sir.
Yes. You will be checking your triceps group when you're flexing. And when you're extending, you check for your biceps. To check the tone, whether for the passive stretch, how much of resistance is present. So throughout the range of motion, when you have to put significant effort and resistance, even the passive movement becomes very difficult. That is when it is grade 3. What is grade 4?
So grade 4 is it's rigid.
Yes, it is rigid extension or rigid flexion. It is contracted and it is there. You will not be able to move it at all.
Yes.
Correct. Next slide, please. Okay. We'll go fast in this. How did you check for shoulder? What are all the movements which you check for shoulder?
So adduction, abduction, flexion,
Yes.
and extension.
Okay. So like that only. So here it is fine, but when you're writing in your examination, always mention shoulder. Below that, all the movements. What were the power? Flexion, extension, abduction, adduction, rotation, internal and external rotation and everything. Okay. So in this, you can see that there is minimal weakness. And the weakness is more pronounced distally when compared to proximally. So that is a feature of a UMN. Okay. Next slide. please go. We'll go a bit faster now. In this, yes, okay, fine. Next, see, there are your no, go to the previous slide. Yes, you can see all your reflexes are exaggerated, so that points you towards a human lesion. Okay, your Hoffman's is positive. Please go. Can you just show to everyone the video once? You can just see. So on, as you can see, there is the flexion of
Thumb
your
and the index finger.
thumb, index finger when the stimulus is given onto the middle finger. So the most important thing in this is you have to extend your middle finger. The interphalangeal joints have to be extended when you're checking, not like this. Extension is important before you start giving your stimulus to see. Hoffman sign is an equivalent of a Bobinski sign in your lower limb. Okay, so how you check your Bobinski sign like that? Okay, so next slide, please. In this will be a bit difficult. Why? Because the patient has significant spasticity, and hence the patient might not be able to perform properly. So that we should not attribute to a cerebellar system involvement. You have to be very careful in this. Because of spasticity, you might not be able to do dysdiadochokinesia. But that does not mean that the patient has a cerebellar involvement. It just means that the patient has spasticity, and hence that is restricting him to do that. Okay, go to next slide, please. So Romberg test is positive. What does that signify?
There's a balance issue, sir.
It signifies a posterior column involvement. Mainly, it signifies a posterior column involvement. Okay. Clonus should have been present ideally in this patient, but unfortunately, every patient, as I said, there are no absolutes in medicine. So hence, clonus was absent in this patient. Next. Next.
Yeah, summary.
So this is a summary. Please read your summary.
So, a 60-year-old male came with complaints of weakness and tingling sensation of the right upper limb and weakness in the right lower limb since 6 months and weakness and tingling sensation in the left upper limb since 1 week, which was insidious in onset and progressed in distal to proximal, and complaints of neck pain since 4 months with a history of electric shock 1.5 years ago and dribbling of urine since 3 months. On examination, the patient was found to have spastic gait, bilateral increase in tone of upper and lower limbs, decreased power in the bilateral upper limbs and right lower limb, bilateral Babinski positive and bilateral hyperreflexia, and positive Romberg sign and Hoffman sign.
Yeah. Okay. So since we are short of time, we'll not be able to analyze the summary. We'll go to the next slide. So that is important. That's why we'll finish that slide. This is very important. This is an important slide because in every neurological case, neurosurgery, not essentially neurosurgery, in a neurological case, the most important thing is localization. Okay. So as madam said, localization can start from the neuromuscular junction, nerve, plexus, anterior horn cells, tracts, subcortical level, then cortex. That is your whole axis, and localization with your history and examination. The effort should be towards to localize where exactly your neuraxis problem is. So you have written that your vertical localization is C5, C4, C5. Why do you tell that?
Because he could not raise his hand to comb his hair.
So what does that signify?
Deltoid could not perform properly.
Yes. So correct. So your neck muscles were normal, but the patient had deltoid weakness, and hence so possible localization goes up till that is the motor level involvement. The cranial nerves are not involved, so obviously your craniovertebral junction and brainstem are intact. So then comes your cervical cord. In your cervical cord, her neck muscles are still working very well, but your deltoid and your supraspinatus, infraspinatus are involved, and hence the lesion most probably the motor level is at C5 level. What is the horizontal localization? The horizontal localization basically means in the cord there is vertebral body, around them there is a dura, then there is a spinal cord inside. Correct? So in that, what is the level of what do you think is the level of your lesion? You're telling extradural. Why do you think it is extradural?
It is more common and age related, sir.
Yes, one, it is his age. Second is it's an insidious onset. It is not an acute onset. So it leads likely to be vascular and involving the cord. Correct? Third thing is the patient has a diffuse neck, dull aching pain. As madam said, dull aching pain is usually caused by not by radicular nerves because it causes radicular pain. It causes more of a vertebral body or a discogenic pain, not a radicular foraminal compression pain.
Sir, I could not hear you.
Hello?
Ah,
Read out, please read out.
provisional diagnosis, sir.
Yes. Finish the slide so we can go to the next slide and discuss that for 2 minutes and finish it off.
Provisional diagnosis, C4, C5 compressive myelopathy. Provisional etiology is degenerative spondylosis, ossification of posterior longitudinal ligament, and benign tumor probably from bone.
So go to the next slide. This is the most important. This is one of the most important slides. So when you've already done all these things, next based on your symptoms and your examination, you have to come to a conclusion of which are the substrates of neuroaxis which are involved. That is, you have weakness, you have increased tone. So it is a UMN type. So that's why your corticospinal tract has been involved, right? The second is the patient, as madam said, the tingling sensation which is there, as well as the patient has Romberg's positive, all point towards a posterior column involvement. A paresthesia also also points towards a spinothalamic tract involvement. And since the bladder, as madam said, you have to and take a proper history again as to what his bladder symptoms were, so the bladder fibers can be involved. So in every neurological examination, this is, if you think like this, it will be very, very helpful to tell which are the substrates involved, and then it will essentially help you towards a diagnosis as well as localization of the lesion. Okay, come to the imaging. So explaining the imaging, you can just zoom in a bit. So yeah. So as you can see, this is an MRI T2 sagittal images, which is showing the cervical cord. So you can see, can you point out where the compression is? With your pointer.
Sir.
Your pointer marker. No, in your presentation itself, you have an option. Okay, it's okay. So the compression is mainly in the C2, C3, as well as C3, C4 levels. That is an anterior compression. You see that black thing?
Yes,
that is the anterior compression which is there behind the disc and in front of the cord. You can also see there are some white specks on the cord. That is called a myelomalacia. That is the weakness of the spinal cord which is being caused by the chronic compression. So at this moment, you can tell me, you can ask me a question, sir, it is black. It is in front of the disc. I mean, behind the disc. Can it be still a disc? I will tell you no, because of two reasons. One, the space between the two vertebrae and the disc space is normal. And another reason is you get a CT done. So you can see in your CT, that is in your sagittal cuts, the second as well as the third cuts, you can see the sharp bony osteophyte which you can see at C2, C3 and C3, C4 levels. So in the spine, there is an anterior in front of the vertebral body. There is a anterior longitudinal ligament. There is a vertebral body and there is a posterior longitudinal ligament. So like a ligament, as anywhere in the body, it's the same composition of collagen. But with age or due to some other reasons, there can be calcium deposition into this ligament. So as it calcifies, obviously it becomes ossified. So that is what has happened here. That there is an ossification of the posterior longitudinal ligament. So in these cases, the most important thing would be to decompress and make the spine free. So that's what we did to this patient. That is, we went through posteriorly and removed the lamina, the spinous process of the involved vertebral body, so that we gave some breathing space to the spinal cord and reduced the compression, and hence alleviated the myelopathic changes. Okay. So since we're short of time, we can have this discussion else some other time. We're informed that we have already crossed a significant amount of time.
Yes, sir.
Okay.
Yes.
Presentation, Eakaika.
Thank you,
The
sir.
And the most important thing is that you got to learn so many things from madam. So all these things have
Yeah,
to be.
madam just messaged me, Dr. Darshan. Madam actually lost connection because of network raining there. But she
Yes, yes,
messaged
yes.
me. It was wonderful presentation. It seems she praised Eika a lot. She told it was one of the wonderful presentations. Because she has conducted hundreds of presentations in White Army. She told this for a UG level. This is a wonderful presentation, and she actually wanted to join back, but she could not. She's trying. She's not able to. But I told her to watch later on YouTube. Okay. Uh, the last part, examination part, Dr. Darshan discussed very nicely. I was also watching continuously. I also learned a lot of things. The way he discussed so patiently and so elaboratively, it's actually good for any PGs, even for good for neurology residents for that matter. But since we want to keep the videos as short as possible for the students to watch, then we'll have separate session by Darshan on this compressive myelopathy management, surgical perspective, separate video on that. Thank you so much, Dr. Darshan. Concluding remarks from Dr. Darshan about the case and the presentation.
Yes, thank you, Kishan. Eakaika, yes, as madam as well as Dr. Kishan have spoken, that it was a very good presentation. You have to be a bit detailed, and you were that detail itself. But the most important thing, what you have to take from this is that the key points which madam has noted in your history. Second, how do you do your examination? That is the most important thing, because still a long way to go for you to learn everything about examination. The most important thing at this point of juncture for you and all your colleagues, all your peers, is that you have to know how to examine properly. Let it come in neurology, abdomen, especially abdomen and neurology. Okay. So if you can concentrate on that, that will be more than enough. Which you for now. Okay.
Thank you, sir.
What Darshan meant was approach is more important than the results. Okay, the findings are not very important for at your level, UG level, PG level. What we expect is whether you approach correctly. The how do you approach a patient? You are examining the proper methods or not. Okay, findings that we are least bothered because that will be taken care of by the consultants and other investigations. Okay, Eakaika, I have seen so many presentations by UGs, but this I should say one of the best in Vitami. So you presented very well, and keep it up. Okay, keep it up the spirit, and please come up with. You have got very good mentors who support you and guide you, and so please come up with some more cases like this. So because of your one well prepared presentation like this, thousands get to learn and get benefited. Thousands watch this video and they also get benefited. Okay, so this is a wonderful opportunity where you can learn from the best of the best, and also simultaneously you can teach others also, your juniors or your friends or even PGs for that matter. Okay, so wonderful presentation once again, and equally like wonderful mentoring by both the teachers. Okay, Darshan, I know from like college days. It's a very good friend of mine, very good teacher as well, very good surgeon now. So Chandra madams also. Thank you so much for all three of you. We also learned a lot because of three of you. Thank you so much, Dr. Darshan and Eikaika. Okay.
Yes, sir.
Thank you, Kishan. Thank you.
Yeah. Aditya, we can end the session.